Thank you, sir, very much. Any question from the audience? Because Sir Suhail has got one question.
Assalamu alaikum, Nadeem. An excellent talk, very exhaustive and very comprehensive. But because we do things the way we do, you didn't mention micro catheters using a stiff wire, which is perfectly acceptable. You don't use it, we understand that. I think one classification which is not mentioned in most of these talks is the MADS classification. MADS classification, like we use Medina to describe what the lesion is like. It helps us tell us what the Medina, which lesions are critical, which area, which vessel is critical. It doesn't tell us more like what is the angle, what is the length of lesion, how much calcium, what there is. But MADS tell you what sequence would happen after you place your first stent, whether you put it in the side branch, main branch, or wherever, and what happens if you cannot recross or re-enter. For example, if you cannot recross a DK crush in your first jailed vessel, suppose you can't recross it in the circumflex, and you have a wire which is still jailed in the crushed circumflex, you open it up and turn it into a culotte. So in a bifurcation, one must always be ready to change the strategy because patient may become unstable. You may not be able to complete a procedure. You may not be able to recross. Some of the side branch may become totally clotted. So it's very important that you keep this backup plan always ready in the back of your mind, and must work out in your mind also what is the strategy. And right up front, you must decide whether it's going to be 2 stent or 1 stent. You might have to use a 2 stent for a bailout. But if it's significant side branch with a long lesion, one must go with a 2 stent strategy. And in those bifurcations with bifurcating significant lesion both branches, there's enough data to suggest that it is much better than provisional. And one must be ready for a 2 stent strategy where there's significant and a critical lesion side branch. So a great talk, and you should go back to sleep, Nadeem. You look very good actually. Don't look, it's 3 in the morning.
So very nice presentation. 2 quick comments. First, one should always try to objectively risk stratify the chances of losing the side branch by applying definition 2 criteria, and if possible we resolve criteria, so that one can decide whether it's a simple or a complex bifurcation requiring an upfront 2 stent strategy. 1. And secondly, as per applying Excel and Nobel studies criteria, they have upgraded the MSA or MLA for proximal circ, LAD and left main stem, which is something like 6 to 7 millimeters for proximal circ, 8 to 9 millimeters for proximal LAD, and 10 to 12 millimeters for left main stem. Thank you.
Thank you, Dr. Jahanzeb.
Yeah,
Sir, thank you so much.
Can I just
Yes, sir, please.
answer this? Yeah. I think देखें ये जो आपको जो आज talk दी है ये basically local perspective. This is what ये जो आपकी 5, 6, 7, 8 पे है, if you get a good round lumen and this kind of thing, there is no, आपको जो उन्होंने जो upgrade किया उसकी आप studies पढ़ेंगे तो it is very selective and it's not. I think this still holds. I'm not saying that the bigger the better. Of course you can do that. But from the locals perspective, we need to have the expertise and the basic standard आपके होने चाहिए. उसके ऊपर you can obviously improve. अब तो image वो IVUS आ गए, उसे आप कर लें. लेकिन ये 5, 6, 7, 8 पे जो outcomes हैं वो कोई खास फर्क नहीं है. And I don't know, you want to go up, that's okay with you. I mean 7, 8, 9 कर लें, उसको 10 कर लें, वो तो जितना बड़ा है. But our European arteries or American arteries are not the same as Asian arteries हमारे यहाँ की.
Sir, thank you very much. And probably we agree with your point of view that there is probably no data on the Asians, especially in our population, to tell about the left main or LAD or circumflex area with the IVUS guided. Probably till that time, whatever we are doing, it's all good.
So sorry for this. Another comment. We all have very state-of-the-art stents which give us excellent result. If I tell you there's a stent which will give you 28% better outcome, will you take it or not? How much money extra will you pay for it? So if you do an IVUS guided PCI, you're going to get a 28% better outcome. Because then you don't have to worry about the size. If it's well approximated, don't overstretch it. So that's the big difference, especially. So I think if you're going to do a left main and a bifurcation, I was going to be a real big advantage to make sure that you get a good approximation and a good long-term outcome.
Sir, thank you very much. This debate can go a long way, even for hours and hours, and it will not end. And Sir Nadeem,
Okay, thank
thanks.
you, Ji.
Sir, thanks.
Thank you, Ji. Thank you. Assalamu alaikum.